This is the case of 5 months old infant in the apical four-chamber view. This is right atrium. This is right ventricle. You can see right atrium and right ventricle dilated compared to left atrium, left ventricle. This is aorta in cross section. Obviously, aorta is posterior to left atrium. This is thoracic aorta. This image shows some sort of abnormality on right side. Our right side pressure has to be increased at the same time. Next image will show you all these findings. Again, you see this is main pulmonary artery dilated. This is again the aorta. This is ascending aorta, and this is thoracic aorta. This is the first part of aorta, and this is the aorta in the thorax that is just behind the left atrium. This is right atrium, right ventricle, pulmonary valve, and this main pulmonary artery quite dilated. You can see this is left ventricle chamber is D-shaped, indicating raised right ventricle systolic pressure. So right ventricle systolic pressure is raised in this case because the left ventricle chamber is D-shaped, indicating raised right ventricle systolic pressure. This D-shaped remains both during diastole and systole, indicating pressure overload. So pressure overload means if there is no pulmonary stenosis, then pulmonary artery systolic pressure is raised in this case because there is no stenosis. You can see this is pulmonary regurgitation jet. You can see this is pulmonary regurgitation jet. This is main pulmonary artery. This is main pulmonary artery. You can see this is PDA. PDA has got bidirectional flow, indicating raised pulmonary artery systolic pressure. Only when the pressure is raised within the pulmonary artery, then flow becomes bidirectional in PDA. If pulmonary artery pressure is normal, in that case flow is always left to right. That means from aorta to pulmonary artery. This is the next image. You can see the pulmonary regurgitation jet. At the same time, this PDA. This is PDA, indicating this case has got persistent pulmonary artery hypertension, likely finding, though this infant is 5 months old, but likely scenario. TR jet is not correctly giving the correct measurement of right ventricular systolic pressure because jet is not prominent. So TR velocity is also not correctly taken in this case. You can see in this image this is the flow across pulmonary valve, that is pulmonary regurgitation jet. You can see this is pulmonary regurgitation jet. This is end diastolic velocity. The end diastolic velocity is 23 millimeter mercury and velocity is more than 2 meter per second. That always indicates severe right ventricular systolic pressure or severe pulmonary artery hypertension. So by calculating pulmonary artery and diastolic velocity, you can say that this case has got severely raised pulmonary artery systolic pressure. So ultimately, this case is likely to have persistent pulmonary hypertension. Next image. This you can see the patent foramen oval. This is left atrium. This is flow through pulmonary vein into left atrium. This is patent foramen oval. So left atrium, right atrium, and this is PFO. This is right ventricle dilated. Again, you can see this pulmonary regurgitation jet. In this image, you can see this is thoracic aorta and this is PDA. This is main pulmonary artery. This image you can see, this is blue. Blue means flow is from pulmonary artery into aorta. The red flow, that is flow means, the red means flow from aorta into pulmonary artery. So you can see follow blue and red alternatively indicating bidirectional flow. Again the same thing, bidirectional flow, 4-chamber view. Now see the nomenclature. So whenever you have doubt regarding patent ductus arteriosus, from right to left, you can see the branches of main pulmonary artery. This is the branches of main pulmonary. This is aorta. This is thoracic aorta. This is right ventricular outlet. You can see this is pulmonary valve. This is main pulmonary artery or pulmonary trunk, and this is the branches: right, left, right pulmonary artery branch, left pulmonary artery branch, and most lateral one, that is PDA. So whenever you find 3 branches coming out from main pulmonary artery, the right from right side, first is right pulmonary artery, second is left pulmonary artery, and most lateral one is PDA. So whenever you find most lateral branch communicating with main pulmonary artery, aorta, that means that is patent ductus arteriosus. So whenever you have confusion, try to find out all the branches coming out from main pulmonary artery. If you find 3, most lateral one is PDA. You can see this is the PDA. This is right pulmonary artery branch. This is left pulmonary artery branch, and this is PDA, patent ductus arteriosus. This is thoracic aorta. This is right ventricular outlet. This is ascending aorta. This is left atrium. This is left atrium. So ultimately, whenever you see bidirectional flow within the PDA, likely the case is having raised pulmonary artery pressure, that is pulmonary artery hypertension. LV chamber is D-shaped, indicating raised pulmonary right ventricular systolic pressure. If there is no pulmonary this pulmonary valve is opening properly. So whenever you find raised right ventricular systolic pressure indicating raised pulmonary artery systolic pressure, that means pulmonary artery hypertension. So this is the case of PFO, patent ductus arteriosus, severe pulmonary artery hypertension, likely to be persistent pulmonary hypertension. This infant is only 5 months old. So this is not Eisenmenger, because Eisenmenger takes time to develop. In case of large PDA, large VST, so this is the only 5 months old infant. So likely scenario is persistent pulmonary hypertension. A second thing, maybe some sort of pulmonary disease causing all these phenomena. Second disease that is called cor pulmonale. Finding of abnormalities of heart due to pulmonary problem, that is cor pulmonale. The first possibility is persistent pulmonary hypertension. Second probability is cor pulmonale. And last probability in this case is Eisenmenger, though it is the least likely. Thank you.